AIOS for having given this opportunity to present my work on dropless cataract surgery. So it's something which is very interesting, and I think that is the only way to move forward. And if you don't move forward, actually you're going back. So this is a technique which we are using for the last 1 year. Now we have done close to around 1,000 cases, and we are very satisfied with the results. But you need to have some precautions and some hindrances, and you should be aware of what can go wrong, so that you are ready for that. So that is the way to go in future, and I think in the next 5-6 years, everybody would be shifting to dropless cataract surgery. So first is, what is the concept of dropless cataract surgery? So the first question which comes in our mind is, why do we need dropless cataract surgery? Or why do we need any medication after surgery? So there are three primary reasons for which we give medication. There are two types of medication. One is oral medication and one is topical medication. So now most of the studies have shown that there is absolutely no role of oral medication in routine cataract surgery, whether it is antibiotic, even painkillers, steroids, oral medication, or anti-glaucoma drugs. If it's a clean surgery, no other pre-existing disorders like uveitis, glaucoma, other things, we don't need to give any other oral medication. Now the topical medication is the mainstay of treatment after cataract surgery, and there are three main reasons for that. One is to control the inflammation, second is control the infection, and third is to control an increase in the IOP spike. So we come one by one. First is, why do we need to go for a dropless surgery? So first thing, and which is most important, is if you can get a surgery done without using drops, there cannot be anything which is better than that. So it makes life so simple. There is no issue of compliance, otherwise the patient has to put 3 drops, 4 drops, 5 times a day, 6 times a day, he misses a drop. Second thing is, the safety profile should be same as that with normal conventional treatment, and the results can be even better. And another advantage of this surgery is that there is a sustained release of drops. So what if you are giving drops, for example, you give a drop now and then you're giving a drop after 4 hours. So there is basically a gap. When you inject a depot preparation, slowly and slowly the drug is being released, and there is steady concentration of the drug in the anterior chamber and in the vitreous. So as you all know, putting eye drops is a cumbersome procedure. The patient can put a wrong drop instead of the right drop which he has to put. Sometimes we have seen that patient has put nasal drops in his eyes or other drops in his eyes, and which led to so much of complication. Then the patient can miss drugs. If the patient is old age, definitely there is a problem in putting the eye drops, and improper handling of the drops. Some people touch the tip of the drop, or some people touch directly the drop into the eyes, and these can cause further problems. So when you are not using any drops, we are relieved by such kind of procedures or complications which may happen inadvertently. Now coming to why we are moving toward a dropless cataract surgery, that is something which we need to understand. So science is evolving, and so are we. So there is a better understanding of physiology. So as I've told, now there is no need of oral medication, and use of intracameral antibiotics have been well proven with ESCRS studies, Irwin studies, and many more studies. They have shown that the chances of endophthalmitis are much less, 5 to 10 times less than conventional method. And there have been so many studies which have been showing that depot injection of steroids give as good results as topical drops. So first was better understanding of physiology. Second is better technique of surgery. So when we go 20 years back, then there was too much of inflammation, too much of power which was used. But now with the good machines and better understanding, we have a very smaller incision, 2.2 or 1.8. Watertight wound integrity is very important, because if watertight integrity is not there, then you can land in problems even in a normal case, moreover with a dropless cataract surgery. Then with machines and with better techniques of doctor, there is very less tissue handling, less touch to the iris, very fast surgery, less thermal damage to the eye, and other things. Other thing which is very important for this dropless cataract surgery is in the bag placement of IOL. Why I say this? Because if the IOL is outside the bag, the haptic will keep on irritating the iris, and that will keep on inducing some amount of inflammation. So when you are using drops, you can control that, but when you are not using drops, there is a chance that that inflammation may increase. So you need to take care of this, and with the modern techniques and with the developments and with the trained surgeons, there is very less chance of PC rupture or doing an anti-vitrectomy. So we have better techniques of doing surgery. Then coming to better machines, as you know, now with the latest machines, we are using with very low phaco power, low bottle height, better anterior chamber stability, and less chances of wound burn. So these all factors have now given us hope to go for a dropless cataract surgery. And then we have better IOLs with less reaction, with better designs of optic and haptic, and the actually today's IOL actually do not produce much of inflammation. Next नहीं जा रहा है. The other thing is better sterilization protocol. So initially sterilization was a big issue, but now with NABH things which are coming on, and biological indicators and class 6 indicators, modular OT, use of betadine in eye drapes, and so many other things, now mostly the infection is not due to autoclave. So either you have not done your autoclave, or the infection is happening through bottle, viscoelastic, blue, or some other things. So you need to take care of your sterilization, and in this thing I need to say two things. One is your sterilization should be perfect with a steam marker or biological indicator. The second thing is when you do sterilization, you must check whether that instrument has been sterilized. We have seen cases where what happens, because the sterilization is being done by the paramedical staff, though the drum which was there, which was used in the last OT, this was not sterilized, with the same drum they have come again, and the same OT they have done the surgery, and that has resulted to mass endophthalmitis. So it is the doctor's duty to check that proper date has been given on that, or steam sterilization was there, whether it is adequate or not, and you have to change it at every step. This is something which is extremely important, and don't miss this thing out. And one more thing which I think is very important, a few days back we had a mass endophthalmitis of 35 cases in Gorakhpur, and we managed 4 or 5 cases out of that. So whenever you are using bottle, because usually bottle is the main culprit in multiple endophthalmitis. So what I do is, I take a bottle in a bulk, maybe 100 bottles, 200 bottles, and the first bottle which I use is the last case in the previous OT. So first I use that bottle, I see that there is no post-op inflammation, and then I start using the same batch of bottle till the batch is ended. So that I'm very sure that the same batch does not contain any infection, and in the first case only one case is being done by the same bottle. So we are sure that, because if anything happens, every blame goes to the doctor and not to the company which is making it. So how to achieve dropless cataract surgery? So it is very simple. You have, instead of topical antibiotic, you are using intracameral moxifloxacin, and actually the 0.1 ml or 500 micrograms of moxifloxacin which you are using is actually 100 times more than the MIC of most of the antibacterial agents. So even if it is slightly resistant also, then also it will take care of all the infection. And once your wound is sealed, there is no chance of any infection which is going from outside to inside in the post-operative period. So well sealing of the infection is extremely important. There should not be any wound burn or any other complication, and the intraoperative moxifloxacin is very, very essential in doing this thing. Second is, you have to, instead of going for a topical steroids, you give a depot injection of 4 milligram of triamcinolone. We have been using, initially we were using only triamcinolone, and there were more reactions. Now we are using other excipients also, and we have seen that the chances of inflammation is further decreasing. So it is still in the study phase what we are doing, but we have seen that usually in more than 95% of the cases there is no problem after depot injection. So coming to a review of literature. So first is to prevent infection. As I told you that many studies, like the ESCRS studies which you can see here, in this study that was a multicentric study with 13,698 cases with an end-off rate of 0.07% versus 0.34% in the conventional group. And these contains all the types of complication, including PCR, anti-vitrectomy, everything. So we are not talking only about the clean cases. Even then, the rate of infection was 5 times less in intracameral group as compared to the conventional group. Now, this was the original study. Now, if you see Arvind's study, that was more than 42,000 cases, in which they have seen that the complication, that the chances of endophthalmitis was less than 0.09%. So these are studies which have shown us that if you give intracameral antibiotics, even without topical antibiotics, then there are other studies also, then the chances of endophthalmitis is almost negligible, less than 0.1%. So this was a meta-analysis of various studies which also shows the same. Second thing is to prevent inflammation. So first was infection, second is inflammation. So as you know, it's an intraoperative procedure, and cataract is a foreign body. IOL is a foreign body. So there is bound to have some amount of reaction, and we need to give steroid to control that inflammation. So what are the mainstay of steroids? Either we give topical steroids, oral steroids, or now we are giving the subconjunctival or subtenon steroids. Now various studies have shown that post-operative deposteroids is a very good alternative to topical eye drops. So I go through a few studies. This was another study from China where they have shown that the chances of inflammation is same or even better with deposteroids. This was another study which shows that triamcinolone is a good alternative to topical steroids. These are various other studies which shows that even cystoid macular edema is less after giving deposteroids as compared to topical steroids. So there have been so many studies with different drugs and different methods also. There have been studies with Ozurdex, there have been studies with a nasolacrimal duct implant of Ozurdex, and there are so many studies which have proven that there are other alternatives which is as good as topical eye drops. The third thing which is most important, especially in this case, is the control of IOP. Because we do not know who is a steroid responder, although we are testing for that, and there can be a post-operative IOP spike, which can be very, very dangerous, and the patient can blame us for that. So even in normal cases, there can be IOP spike due to pre-existing glaucoma or due to intraoperative complication, or if the patient is a steroid responder, there can be an IOP spike. So we have to take these things into consideration. Now this is the most important slide when you want to start doing a dropless cataract surgery. First is ethical committee approval. This is not a standardized procedure till now. So unless we have a ethical committee approval, we cannot start doing a dropless cataract surgery. So we have an in-house ethical committee, and this has to be approved by CDSCO. Then only you have been approved, and we have to give the results every week to the ethical committee so that we are sure that we are not doing any harm to the patient. Second is the patient consent. So detailed patient consent both in oral and written form is extremely important. If you do this surgery without a consent and if you are in a problem, then you will have to face the consequences. So you need to have a written oral or ideally a video assisted consent when you do start doing this kind of surgery. Third is you have to explain the risk benefit ratio to the patient, which I will be discussing later, because unless you explain this and you just get it signed, it does not have any meaning. So you can say it's a safe procedure. We have done 1,000 cases and it is being done worldwide. If you want to go for this study, we can include you in this study. And another thing which is very important is, if let's suppose there is a patient in camp who comes to you and you do his surgery, give a depot injection and he goes off, and then there is a complication after a month, you are responsible for that. So you need to ensure that the patient is ready to come whenever you ask for him, and if there is complication, he can report to you immediately. You cannot just give an injection and let him go. So the patient has to give a consent for a close follow-up. And one more thing which is very important is you should know how to remove the subtenon triamcinolone in case there is a steroid response or there is something else. So it's not a very difficult thing. Video hai steroid iska nikalne wala. Okay, that is a very simple technique. You just go subtenon, remove all the tissue along with the deposteroid, along with the fibrous tissue which is there, and you can get it removed. So that's not a very difficult thing, but you should know how to remove it if there is any complication. So this was the prerequisite and the basic concept of doing things. Now I invite Dr. Neha Shilpi, who is a consultant at our place. She is a fellow from Narayana Netralaya and she did her PG from RP Center AIMS. So she would be speaking on the technique and the requirements and the selection criteria for cataract surgery patient. Because see, this is something which is not, you cannot do in every patient. You have to be very, very selective when you are doing, especially in the beginning. You cannot take, so she will be telling you about this thing, and then I will tell about our experience and other things. Thank you, Dr. Neha.
So, thank you, sir. So, sir has already introduced me, so I'll go with my talk. So, I'll be discussing the technique of performing dropless cataract surgery. So, how do we actually do it? So, a good preoperative workup is very essential in these cases, and especially focusing on the glaucoma part. So, we have to carefully assess the cup disc ratio, and we have to carefully check the intraocular pressure. Preferably, we should check it by applanation tonometry. Okay. So, in all preoperative cases, IOP should be measured. And the other very important thing is it should essentially be a routine cataract surgery, essentially an uneventful, totally uneventful surgery. What we are doing right now is we are giving it only in routine cataract surgery cases. There should not be any other associated ocular disease. No intraoperative complication should have happened, and it should be a clean surgery, as I mentioned. Another important part is the insertion of IOL should be under hydro. So the IOL insertion should not be done under viscoelastic for these cases, because we don't want any retained visco. Even after careful wash, there is some amount of visco might remain at the end of the surgery. So we don't want that to happen, because that might lead to post-op IOP spike. So the IOL insertion should be done essentially under hydro. Intracameral moxifloxacin, as discussed, is to be injected at the end of the surgery. So triamcinolone is available in vials. So it's 4 mg per ml of vial is available in the market. So we have to take that, and 0.25 ml of that is injected in the inferior subconjunctiva or subtenon. So that site is preferred because cosmetically also that's better. We don't want anything to be seen by the patient, because that depot will remain for some time. So we inject it and in the inferior subconjunctival region, using a 1 ml insulin syringe and a 26 gauge needle. So this is the video. So this is a case of cataract. It's a white cataract, but not very hard. We don't want very hard cases, because more phacoenergy will be used in those cases, and those might need anti-inflammatory drops. So we are not including those patients. So we see after Rex's, now hydro is being done, and then primary chop is being done now. So as I discussed, it should be essentially an uneventful surgery, a clean surgery, with no tissue handling, no iris cut. All these things should not be there.
I'm a king, but I bop, I'm a saint. They call me a bad man, that's a fucking good thing. Mama said swing back when another...
After the emulsification, cortical cleanup this is also very important. There should be a thorough cortical cleanup. We don't want any residual cortical remnant. Then the IOL insertion is being done under hydro. The IOL has to be implanted in the bag. So the IOL is being nicely placed in the bag, and any residual viscoelastic is being washed. So after the hydration of the wound, we'll now inject intracameral moxifloxacin. So that is being injected in the AC. And then in the inferior, this is the subtenon injection of triamcinolone. This depot injection is being given, and we see this depot is there now. So these are the photos of the patient. So see this depot can be seen there in the inferior. So if the patient recedes his lower eyelid like this, the depot can be seen. So we have to preoperatively also we have to explain to the patient that there is this white thing which can be seen if the patient pulls his or her lid down. So the patient should not get afraid by seeing this. The patient has to be explained that this will remain for some time and will eventually go by itself. Other agents which are also being tried and studied are dexamethasone, Ozurdex implant is also being put, fluocinolone implant, methylprednisolone depot injection, tyrosine kinase inhibitor, and there are some few other excipients which we are also using along with triamcinolone, which are under study. So the routes are also different. Some in few studies they had tried intracameral also, but obviously the retention time was very less. Then subconjunctival, subtenon, and then there is this study in which intracanalicular insert has been put. So there is 0.4 mg of sustained release dexamethasone intracanalicular insert, which comes by the name of Dextenza. So this was implanted in the patients, and the result was favorable in terms of overall satisfaction, convenience, and comfort. It was well received and preferred over topical therapy. So now we come...
Just 1 minute, yes, if you allow. So there are 3-4 things which are very important. Even there was a study by Donenfield in which he has given Ozurdex implant in the patient with who they are doing with dropless cataract surgery. So there are 3 things which are very important. One is hydro insertion of the lens. We don't want viscoelastic to be there, number 1. Number 2 is extensive cortical cleanup. We don't want any remnant of cataract to be there. Third is wound sealing. that is extremely important. The wound should be watertight, and you have to be sure that the wound does not leak or there is no influx of outside fluid into it. And fourth is, at the end of surgery, you have to put 1 drop of atropine. That is very important, because you want at least 1 week of cycloplegia after the surgery, because you're not doing any drops after the surgery. So these are few things which are very important for this surgery. And if you master a good cataract surgery and you follow these principles, so you can definitely go for dropless cataract surgery.
Yes, thank you, sir, so for highlighting these points. So now coming to patient selection and precautions during surgery. So we are including patients who are more than 40 years of age. We are not including pediatric and very young patients right now. The patient should be having cataract, but it should not be a very hard cataract or posterior polar cataract. Fundus examination should be perfectly normal. We are excluding one-eyed patients for the obvious reason. We don't want to take any chance in them. Patients with any history of systemic illness like diabetes, hypertension, prostate disease, patients on alpha agonists are not included. We are not taking subluxated cataracts. Patients with any history of uveitis are not included. Patients with very severe dry eye, severe meibomian gland dysfunction, those patients are also excluded from our study. Patients with glaucoma, any intraocular hypertension, or those who are steroid responders, those patients obviously have to be excluded. Patients with history of corneal ulcer, history of steroid intake before or during surgery, patients with any retinal pathology, vascular occlusions, diabetic retinopathy or hypertensive retinopathy are excluded. Patients with history of any ocular surgery like minimal invasive glaucoma surgery, keratoplasties, retinal surgeries, all those patients are not to be taken up. Patients with pseudo exfoliation, patients with pigment dispersion, those patients are also not included in the study. So this preoperative workup, this is very essential. So this point I already discussed, intraocular pressure. So this is very important. We have to check it very carefully. Another very important thing to know previously is steroid responder. So what we do for this is we give topical steroid drops, dexamethasone drops for 3 days, and then we check the IOP. Before starting the medication, we check the IOP, and after giving it for 3 days, we check it again. And if the difference is more than 6 millimeters of mercury, so then we should not go for dropless cataract surgery. Those patients we label as steroid responders, and we are not doing dropless cataract surgery in those cases, because removing that triamcinolone depot will be a challenge afterwards. So as I discussed, in preoperative assessment, we have to check the intraocular pressure. We have to exclude the steroid responders. We have to carefully assess the cup-disc ratio, and we have to carefully take the family history of glaucoma also, so that we know beforehand that these patients have increased risk of developing glaucoma. Severe meibomian gland dysfunction patients with severe dry eye are also not included because of increased risk of infection and inflammation also in those patients. Cells in anterior chamber have to be very carefully assessed under the slit lamp, because even if there is a sign of any minimal inflammation also, those cases we can't take. We have to carefully do the indirect ophthalmoscopy and rule out any intermediate uveitis. So we see any haze in the vitreous, any vitritis or any sign of intermediate uveitis, we have to exclude those patients. We have to rule out Fuchs endothelial corneal dystrophy, Fuchs heterochromic iridocyclitis also. So even after all these preoperative assessment, it is very important. We can counsel the patient that dropless cataract surgery can be done for you. So we have to take the consent from the patient accordingly. We have to explain to him. But even after going through all these things, we can't promise dropless cataract surgery to any of the patient, because if anything happens intraoperatively, so if there is any intraocular complication, we have to switch to the conventional therapy. We can't continue the patient for that dropless thing, and we have to switch to the conventional therapy in those cases. Similarly, in the post-operative period also, if everything happened uneventfully in the intraop, and we have recruited the patient for dropless surgery, but in the post-operative follow-up, if we see that there is a spike of IOP, or we see that there is inflammation which needs treatment by topical drops, so we have to switch the patient to the conventional treatment. So in each and every patient, we have to explain them very properly that dropless cataract surgery can be done for you, but the ultimate decision will be taken in the operative room, and subsequently also depending on your condition, your eyes. So intraoperative complications which we should watch for, and patient has to be excluded if any of these happens, is the most important thing is posterior capsular end. So if there is any breach in the posterior capsule, so we can't take up that patient for dropless surgery. So if there is vitreous in AC, if there is iris touch, if there is tissue handling, we have to exclude those cases also, because there will be more inflammation in the post-operative period. If there is iridodialysis, if there is descent membrane detachment, if there is wound burn, so all those cases we have to exclude. So as I discussed, it has to be essentially a clean surgery, an uneventful routine cataract surgery. Another important point is lens has to be implanted in the bag. So if for some reason, if there is sulcus implantation of the IOL, we don't take up those cases because we anticipate more inflammation in the post-op period. So this is the slide for case selection. So these are the cases in which we are doing minimal incision cataract surgery with minimal inflammation. Hydro insertion of IOL is being done in all these cases. No use of viscoelastic during IOL insertion. Lens has to be in the bag, and good quality IOLs are used. We are not including cases of very hard cataract because we don't want cases in which more energy is used in drop. Tissue handling, iris touch should not be there. Those are no for these cases. Any case of guarded visual prognosis. So we are not taking those cases. Those are no for these cases because they, in the post-operative period, they might attribute this less gain in vision to not putting drops. So we don't want this to happen. So we are not including cases with guarded visual prognosis. Any other intraocular pathology cases are not included. So prerequisites are, it should be done by expert surgeon because the surgery time will be less and it will be a clean surgery using a good machine so that less phaco power is used, no iris touch, no PCR. In the post-operative period, we do follow up on the next post-operative day at 1 week, 1 month, 3 months and 6 months. So in all the visits, we check for best corrected visual acuity. We check for intraocular pressure. So intraocular pressure is measured using non-contact tonometry on the first post-operative day and at 1 week follow-up. And later on, it is done using applanation tonometry. Then careful slit lamp examination is being done to check for corneal edema, descemet fold, any signs of infection has to be very carefully, wound integrity, any sign of infection has to be very carefully assessed. And using the sun classification, we check for any cells in the AC. So these things are to be done at all the examinations. Thank you. Now I'll again invite sir to discuss about the risks and benefits with this technique.
Just one thing that we are using AST, that is anterior subtenome. Can't we use the PST in the place of?
The thing is, the reaction is basically happen in the anterior segment. PST is being given when there is chances of CME or there is a posterior chamber disorder. So we are giving AST because the inflammation is going to happen in the anterior chamber and AST will have more effect as compared to the anterior chamber inflammation. So that is the reason we are giving AST only or subconjunctival. Okay. I know. I know. But if you, in private practice, if you wait for 1 week, in most of the, but what we have seen, and that is why we have decreased our threshold from 8 mm to 6 mm. So what we have seen that if there is steroid responder, within 3 days also, there is an increase in IOP.
Number of cases comes 3 days is very less.
I know.
As I'm a glaucoma person.
Yes, I totally agree with you. Ideally, it was 2 weeks. Ideally,
it is 2 weeks or 4 weeks also. Journals,
yes.
all articles gives 4 weeks.
Yes.
But minimum.
The cases going to 40 or 60 mm, just a 1 day use.
That's why what I'm saying. So if there is a mild steroid responder, still you can try.
Most of the patients can be picked up.
Yes. So, yes. So basically you have to see about the IOP, you have to see the CD ratio, because many of the patients you can pick even after 3 days or 7 days of steroid. You can go for a 7 days, that will be still better.
Usually 7 days is better.
Yes, I totally agree with you, but as the protocol we are following is for 3 days only.
There was one more concept of putting that TA into the zonual region.
I know.
Do we have?
No. They have so many studies, but we are not doing that. Because see, injecting anything intraocularly, you cannot remove. For example, if you are using in the posterior segment, in the anterior chamber, in the zonal region, if something goes wrong, then you are in a very, very big problem. If it is subconjunctival or subtenant, you can remove it. So safety wise it is better, and what we have seen with our results that there is actually no problem if you are doing anti-septorin or subconjunctival triamcinolone. So if you can do something which is extraocular, it is always advisable than going intraocular, because intraocular means there can be so many complications.
But when we put this TA into the vitreous cavity, that is intravitreal
Yes.
triamcinolone, then we can remove it by vitrectomy very easily. I think
know.
that is the easiest place from which we can remove the TA.
Okay, but you need to do a vitrectomy. That will be a big procedure, and most of the people are not having that.
Yeah.
So
I agree. I
and
agree.
vitrectomy has its own complication. Yes, yes,
I
and
agree,
vitrectomy
I
has its own complication. There can be so many things associated after vitrectomy also. So it is always better to do an anti in the subtendon space rather than going for intravitreal.
Yes. But the most safe thing in the eye for the TA is the vitreous cavity.
No, I do
Be-
not
be-
agree with you
because
directly. It is very safe, but if there is a steroid responder or if there is something else which happens with this,
then
and you
can
do a
remove it
vitrectomy,
Toto.
huh?
Then if the patient is a steroid responder and your TA is in the vitreous cavity, you can remove it Toto.
I totally agree with you. No,
that-
even subconjunctivally you can remove it total. That's not a problem. But doing a vitrectomy surgery for after cataract surgery,
That I agree.
that would be
Totally
a big thing for the patient. Yes. So now we move to the next topic, which is the risk and benefit ratio before evaluating for a dropless cataract surgery. So what are the basic risks in doing a dropless cataract surgery? So I go one by one. One is infection, which can be immediate or delayed. So usually we do not see immediate infection or not even delayed position. But sometimes what can happen is, since you are not using drops, if there is a infection like Propionibacter macronis or staph epidermidis, so a small amount of infection can remain in the eye, which can present in the later phase. So you have to be very, very careful, and you have to know about this type of infection, and the moment you find something, you have to treat it accordingly. If you see a severe infection after, let's say, 1 month, then you start giving intravitreal antibiotics, or if you have a doubt of infection after 1 week, don't hesitate to start your topical medication. So the take-home message is, when you're doing a dropless cataract surgery, don't promise to your patient that you will be doing a dropless cataract surgery. In 99% or 98%, you will be successful in doing that surgery, but you have to be you have to tell your patients that in case a drop is required, we may add drop anytime. Even after 1 month, we can add drops for your surgery. Second is inflammation. That can also be immediate or delayed. Now, what we have seen with our study is that contrary to that is the most important thing which we feel, that we have seen multiple episodes of reaction after 1 month, 2 months, 3 months after the surgery, and which is more as compared to the conventional surgery. So in conventional surgery, usually after 1 month, you don't get repeated inflammation. In this, in few cases, it's not too much, but in few cases we have seen repeated inflammation after the surgery, and this you should be aware, and you need to treat that patient accordingly after that thing. Third is IOP rise. So this is the most important thing, IOP rise after the surgery, which can be immediate in the first week, or maybe even 2 to 3 months after your surgery. So you have to be well aware of this thing, and if there is anything, you have to take adequate measure, whether it is topical, whether it is surgical, or removing the triamcinolone, whatever it is, you have to be ready for that. And don't charge your patient in case you need to do a trab or something. We have not got any case in which we have to do a surgery, but you have to be ready for that. You should know how to remove the triamcinolone, you should know how to do a glaucoma surgery, and you should know how to do other things if the complications are there. And you should have a retina backup with you. So let's suppose there is an endophthalmitis, and then you say you go to another doctor, so patient will see, will attribute everything to you because you have done a dropless cataract surgery. उन्होंने कहा दवाई नहीं डाला इसलिए infection हो गया और इसीलिए problem हो रही है. So you need to tackle that position at your center only. The other thing is, in literature we have seen there are few cases of scleral necrosis after subtendon injection of triamcinolone. So that is very rare, but you need to keep that in your mind. And CME. What we have seen with our study is that actually the incidence of CME is less as compared to a topical study, because there is a depot implant which is there. Slowly and slowly the steroid is being delivered to the eye, and actually the CME is less. But we need to do more studies, and then only we will be able to commit. So this is a study which is still going on, and as of now we are having good results as regards to CME. So coming to the benefits. So as I started with my presentation, what does the cataract patient want after the surgery? There should not be any pain, there should not be any complication, he should not be using any drops, and he should see good. So these are the something which are required. So till now we are giving everything to the patient except that we are giving drops. Now once we stop giving any medication to the patient after surgery, what better can be that to the patient? You come to the hospital, you don't put any drops, you just start with your surgery, go out, and you're not putting any drops. So this is something like magic which is happening, and with care, with some amount of, you have to be careful, you can do this kind of surgery. Then the other thing is there is no compliance issue because you're not any drops. So no drops, no compliance. Third is continuous delivery of medication, as I told you. Fourth is less chance of CME. And then if you calculate, you are actually decreasing the cost. If you're giving 3 drops for 1 month and you're just giving a 10 rupees of triamcinolone or 20 rupees of triamcinolone. And one more thing, this triamcinolone what we are using has to be preservative free. Don't use a preservative triamcinolone in your cases. So Orocort which comes is preservative free triamcinolone. You can use that or any other preservative free triamcinolone which you can use, but don't use a conventional preservative triamcinolone which is the thing. And then
What's the reason for this?
again same thing. With any kind of preservative, it's not a study which has been done, but what we can assume is there can be more inflammation with the preservatives or something like that. So now since preservative free eye drops are available, you can simply go for that. So nothing very serious about it, but what protocol we are following is a preservative-free triamcinolone eye drops, triamcinolone injection. And what at the end you want is your happy patient. So if you do a dropless cataract surgery, you won't find a more happy patients than a conventional cataract surgery. So now let us tell our experience. We have done a prospective surgery for the last 1 year, and till January, mid of January, the total patients was 671. Now it is close to 1,000. And the study duration was in last year in March we got the ethical clearance, and we had to really work very hard to get the ethical clearance, especially by the CDSCO. So ultimately we could convince them, and then we got this study, and now we have done around 1,000 cases, and minimum follow-up is more than 1 month. So coming to our results, now see the immediate rise of IOP of more than 26 was seen in 32% of cases. Now, but when we started comparing with our conventional surgery, then also we found that on first day, the IOP rise is there. So it is not something which is very wrong. If you start evaluating your patient on first or post-op day, the IOP rise is there. So, and you don't need to actually give anything for that. If it is, let's say, around 30 or even 35, if it is more than 40, then definitely you have to give. But if it is less than 30, you can simply wait, and you'll see in the 1 week, more than 80% of the, I think 86% of the cases, the IOP came down to 21 without any medication. Okay, so only in 6% of patients we require to give a post-operative anti-glaucoma medication after 1 week, and in 0.6% of the patients we required glaucoma medication after 1 month. So that was, and in those cases we had to do a trabeculectomy surgery or remove the triamcinolone. We have removed triamcinolone in other cases, but not in this study. Coming to inflammation, the inflammation was usually not present in day 1 in majority of the cases. In 4.2% of the patients, we gave topical steroids on day 1 as the inflammation was more, and in 2 cases there was fibrinous exudate. So we had to give oral medication and topical steroids, oral steroids and topical steroids also in those 2 cases. In 6.2% of patients, we had to give topical steroids at 1 week. So initially inflammation was not there, but after 1 week we could find that cells were around 3+, 4+, and we had to give topical medication. And 6 patients presented to us before 1 week. 6 patients presented to us before 1 week with signs of uveitis, for which we had to give topical steroids. So these were patients, within 1 week they presented again to us in around 800 cases. And we had to start giving steroids because of there was inflammation which was present. And 4 patients presented late after 1 month. So 1 month, everything was very well. No problem, nothing. After 1 month, maybe 2 months, 3 months time, they presented with inflammation. So we don't know whether that was a normal inflammation or it was related to this surgery, but then we had to start the topical steroids after that. So not even a single case of endophthalmitis was there in the whole series. There was 1 case of endophthalmitis in a case of PC rent, in which a PC rent occurred, and however that case was excluded from the study as per the protocol, because once there is a PC rent and anti-vitrectomy, you cannot go for a dropless cataract surgery. Coming to the visual outcome, so on day 1, it was around 14.2%. This is unaided visual acuity. So this is not aided visual acuity. On day 7, it was 31%. 6.9 was 54%, and 6.12 was around 14%. So this is unaided. If you calculate the aided visual acuity after 1 month, I think more than 99% had 6.6 vision corrected visual acuity. complications, severe complications. 2 had vitritis, 2 had fibrin exudate in AC. So total, there were 4 severe inflammatory cases in this study, and which we had to manage by both oral steroids and topical steroids. So the next question is, after learning everything, how do you start doing a topical dropless cataract surgery? So first thing is, you should be sure what you are doing. First, how is your surgery? How is your IOL? Can you do a hydroinsertion of the IOL? Can you do a black placement of the IOL? Can you do a very, very clean surgery? So it is not for something or someone who is just starting to do a cataract surgery. So if you're an expert surgeon, good machine, good OT infrastructure, ethical committee approval, which is most important, written consent, then only you start with this. So first is ethical committee approval and written consent from the patient. Second is, evaluate your own normal surgical complications and surgery. Then only you proceed. If your complication rate is higher, I think that's not advisable. You go for a dropless cataract surgery. Third thing is, start in a graded manner. So what I would suggest you to all those who are doing cataract surgery, now let us, what do you mean by graded? If you are using oral medication, so in the first stage, stop giving oral medication. Okay, so if you're giving oral ciprofloxacin, painkiller, other things, first stop giving and see your results, whether you are satisfied with that. Unless you are satisfied with stopping the oral medication, don't go for dropless cataract surgery. Second comes the drops. And even in oral medication, you no need to give astazulamide or other things, other agents, even steroids. You have to see that the patient is doing fine. Then you go for the second stage. In second stage, what do? Is you just give intracameral antibiotic. You take a consent. Don't give topical antibiotic drops. And you follow your patients. Follow for at least 3 months. You should be convinced that, because see, anything which the literature says may not be true in your hands. So you should be convinced that after I have done 500 cases or 300 cases in which I have not given any topical antibiotics, there was no complication. There was no endophthalmitis. So once you have gone through the second stage, then only you go for the third stage, that is injection of depot withdrawal. Then only you can go for a dropless cataract surgery. And then you should be very, very sure that your IOP is under control. See your CD ratio yourself. Don't give it to the residents or optometrists and they give it. See, evaluate all these patients yourself. See that there is their CD ratio is fine, the IOP is not there, the patient is not a steroid responder, and there are no other complications. Look for pseudoexfoliation syndrome, look for Fuchs endothelial dystrophy, look for Fuchs heterochromia idiopathitis, look for pigmentary glaucoma. Otherwise, what happens? You think it is a normal case, you do it, and then you land up in problems. So you have to be very, very cautious before you start doing this thing. Look for post-operative inflammation, and then you can do. So just to conclude, dropless cataract surgery is a safe, economical, and very, very satisfactory surgery to the patients. Pre-surgery evaluation, non-complicated surgery, and rigorous post-operative follow-up is the prerequisite for a successful outcome. Never promise dropless cataract surgery to your patients. Start in a graded manner. Don't jump on it. Okay? And ethical committee and consent is something which is extremely important, and then only you can start doing it. So those who want to start doing this, they can call me directly and contact me. We can provide them with the ethical clearances and the drugs, everything we can do them. We need to involve them in the study. We have to take the ethical committee for a multi-study trial. We can do that, and we have to evaluate case by case basis for such cases. So if anybody is interested in doing that, the email and phone number is directly there. You can contact me, and then we can have a multi-center trial. We can start that. So that was the basic about the dropless cataract surgery. So it is in the beginning phase, but various literature is available, and people are doing it. And in more than 90% patients, it will be really a dropless cataract surgery. Patient will have a wonderful response. Only thing is, you have to be true to your patient. You have to give the consent, take the consent, tell the patient what is happening, and follow the patient. And if there is any risk, you have to take responsibility for that and do ahead. So this is the way to go. And I think as science is progressing, and as I told you, what are the basic things which are required, in future times, dropless surgery is the only way to go after cataract surgery. So I'm not saying about pterygium surgery or retina surgery or other surgery, but for cataract surgery, if you're a good surgeon, if the case is clean, the surgery is clean, there can be nothing better than dropless cataract surgery. So thank you very much for your patience, audience. If there are any questions, I will be more than happy to answer them.
To stop using the oral medication, do we need to take the prior approval of
No, 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 no. See, it is very well standardized that oral medication has no role in cataract surgery. I have not been using oral medication for the past 20 years. When I was in BHU in 2000, up to 2003, my process, everybody started. Then when I became a consultant there, I stopped it, and I have never faced any problem because of not using oral medication, whether it is painkiller, whether it is antibiotic, whether it is Dimox or anything. I've never used unless there is a complication or there is a pre-existing problem. For example, if the patient had a uveitis, then I obviously give a steroid 3 days prior to the surgery and do. That's a different thing. But in a routine, clean cataract surgery, if there is a complication, if there is too much inflammation, if there is a PC rent, then definitely have to give. But otherwise, there is no role of oral antibiotics or oral steroids or oral anti-inflammatory drugs or oral anything before the surgery.
I think there is a midway also. I give antibiotic and steroid only for 10 days. For first
Drops, na?
yeah, drops.
Yes, yes, yes.
Only for 10 days, and after 10 days I just stop all the medication. I just put the patient on the NACID.
Yes, yes.
And that is a midway between going
Yes, so
to
that is also standard.
dropless to, you can say, using steroid for a 45 days or a 50
So
days.
that
I
is
think
also standard
that's
protocol.
also been
Many
done.
people are doing that, especially in West. They are following this protocol only. So definitely, actually the role of antibiotic is never more than 1 week, even if you give topical antibiotics. It is mainly the steroids. But that depends totally upon the surgeon and the type of surgery he's doing. If it's a clean surgery, even after 1 week you stop, don't give anti-inflammatory, then also in most of the conditions nothing is going to happen. So you have to evaluate yourself. It is not something that I give you and you take it and you start doing it. Ultimately it becomes the surgeon's decision. So you have to evaluate yourself, that's what I told you, start in a graded manner. Start stopping oral medication, then one by one antibiotic, then steroids, then other things, evaluate your patient, and then only you try for going for a dropless cataract surgery. Yes, madam.
Pre-operative topical antibiotics or NSAIDs, usually
No.
we use 2-3 days prior.
We don't give. And I have been using, that's something which is off-label or whatever. See, the literature says that at least 2 days or 3 days you have to give. But we have not been giving pre-operative antibiotic for the last 20 years, and I don't think there has been any problem. We definitely use antibiotic at the day of surgery and betadine before surgery, at least 5 minutes before the surgery. And various studies have shown that betadine prophylaxis is even better than giving topical antibiotics. So betadine is something which you cannot neglect. You have to give that before surgery, and we give it 10 to 15 minutes before surgery and at the time of surgery also.
See, the thing is that when we give the intravitreal injections, we don't give the pre-op antibiotics.
Yes, and
even after the injection, we don't give any antibiotic.
And actually
So
that is more
vitreous
dangerous because you are
more
giving
dangerous.
directly into the
directly
vitreous cavity.
Yeah.
Huh.
So that is more dangerous. So there is no,
And
see, for legal point of view, we are giving, we are starting antibiotic 2 days prior to the surgery. But frankly speaking, I don't find this scientifically a good thing. But just for legal point of view, we are writing. So that at least if any problem is there, we can say that okay, the patient was on antibiotic. Because practically it don't seem.
So
to be
actually
any
there is not much role of oral antibiotic. Actually speaking, there is actually no role of antibiotic. And if you go to the Western countries, especially Finland and Sweden, in those conditions, it is banned to give any kind of antibiotic, even in cesarean section, even in surgeries, in which the infection chances are very high. So they are banned from there unless there is a complication. So actually we need to go to that protocol. The OT has to be clean, your instruments has to be clean, everything has to be clean. So you need to definitely put a lot of stress on your OT before you start doing anything which is away from the routine procedure. So any other question, madam? Any other question, sir? So thank you so much for this instruction course, and we hope that in future you start doing the same thing. Thank you so much. Thank you.